Good afternoon, everyone. I am so glad that you could join us today. Once again, my name is Deanna Paddack. I have spoke to you a couple of times now on substance use disorder, human trafficking, and to wrap up our series, we will be talking about CRAFT, a model on how to communicate with patients and family members who may be dealing with substance use disorder. And you may see these individuals in your emergency room, in your acute care settings, in outpatient settings, and able, I hope, to utilize the information that we talk about this afternoon and the information to give you regarding CRAFT. CRAFT actually stands for Community Reinforcement and Family Training. It is more of a behavioral model that you can utilize, again, to talk to patients, family members, and individuals dealing with substance use disorder. Next slide, please. So we'll just kind of jump in from here. One of the reasons I wanted to introduce this model to you is this is something that I am passionate about. This is something myself that I took the time to understand and obtain my certification and training for, and have utilized it not only professionally as a registered nurse. I've also used it personally in my own family and dealing with my adult son's substance use disorder. Part of CRAFT that we're going to talk about today is excluding the family training just for the audience purposes, understanding that you're really more focused on the patient or the individual versus providing family training. So we're going to look at the CRAFT model from a community reinforcement approach. Really what that is and what CRAFT in general is. It was founded by Dr. Robert J. Meyers. He's a Ph.D. He currently practices in New Mexico and Texas. It is evidence-based. It has been studied and has had very good outcomes with changing individual behaviors for those people who are dealing with substance use disorder, whether that's alcohol or additional substances that they're using. So what it really is and what it's looking at and what it really deals with is a comprehensive behavioral program that really is aimed at treating substance use disorder. There's environmental contingencies that we do know, both from a provider standpoint and a personal standpoint, that the environment plays a role in whether we encourage or discourage substance use. And I can see this firsthand, both again in my personal life with my adult son, as well as my professional life as an ER nurse, and really understanding the language that we're using, the way that we approach individuals, really can encourage them in trying to obtain sobriety, even if it's just for that hour or two, or really kind of give them the go-ahead to continue using, all because of the language and things that we're portraying to individuals. It also utilizes social, recreational, familial, and vocational reinforcements. It provides more sober lifestyle choices and outcomes. CRA, Community Reinforcement Approach, which we'll abbreviate to CRA for this presentation, has the strongest scientific evidentiary efficacy with the least amount of clinician engagement or knowledge of the principles. CRA is a broad spectrum behavioral program and has been supported with inpatient, outpatient, and homeless populations. Next slide, please. So CRA really has 8 steps to the procedures, and we'll go through each one of these, but just for the short time frame so that you can have the overview and really understand what are the 8 steps to community reinforcement and its procedures. The first one is a functional analysis of substance use. Then you have sobriety sampling. Then you're going to develop a CRA treatment plan, behavioral skills training, offering job skills training, social and recreational counseling, relapse prevention, and at the end, really relationship counseling to kind of bring it all together and tie it together. Next slide. So an overview of the functional analysis of substance use. It is meant to be utilized as an antecedent by exploring whether these antecedents will elicit positive or negative consequences of the substance use. It allows the clinician to begin understanding the drive for the patient-client use. What you see on the right side of the screen here is a kind of like a checklist, a skills list that is a downloadable form that you can utilize at the end. In the reference section, it will take you directly to these forms that if you want to use these forms, they're there for you. Again, Dr. Meyers developed all of these and put these together. I really liked the form because I think it's short. It's something that even in an ER setting or an emergent setting where you don't have a lot of time to spend with your patients, that you really can drill down some things for them and get them to just start thinking through these things. And even to take these things with them if they want to follow up and have follow-up counseling or follow-up outpatient treatment, or even the inpatient treatment side. It looks at external triggers and really asking the questions of who are you usually with when you're using, where do you usually use, and what time or when do you typically tend to use. Then we are looking at internal triggers, like what are you thinking about before you're using, and that's immediately prior to your use. What are you feeling, physically feeling prior to use, and emotionally feeling. Then it's talking really about the behaviors when you're using substances. You know, what is your drug of choice? We hear this a lot, your DOC or your drug of choice. How much are you using when you use? And over how long of a time period are you using that? And then you've got short-term positive consequences. What is the patient or the individual gaining short-term from their use? And then making them look at, okay, you have the short-term use. What are the long-term negative consequences that are going to occur because of your use? Next slide. So step 2 in the community reinforcement approach is talking about sobriety sampling. This is a contract. It's an agreement with either the clinician and the patient or individual to individual that says, okay, for this amount of time, and it's a limited time period, I'm going to abstain from using. And really keeping in mind that when you see these individuals in an emergency setting, a lot of times you're seeing them because they're there from an overdose. Maybe they're there because they're having a mental health crisis. They may be there because they're withdrawing and feeling physically ill. So their use is really not that distant to them. And so sobriety sampling, we wouldn't anticipate that we could say, okay, for the next week or even 2 weeks or 30 days, you're going to abstain from using. It's really offering small chunks of time and trying to get them to agree to a contract, for the next, once you're discharged here, for the next 10 hours, you're not going to use, you're going to try to maintain sobriety. And then once you hit that 10-hour mark, really extending that time out. It's really just simple as offering options and suggestions of different things that they could do to not use for 24 hours, and extending the time or days as they get this chunk or this block of time behind them. Next slide. The third step in the community reinforcement approach is the treatment plan. And really, this is for the clinician to obtain a baseline on the happiness scale, which you'll see on the right side of your screen, so that you can have a more structured way to identify any area of discontent and a way to be able to scale that for progress so that we can show that patient, show that individual or client the progress that they've made. It assists them by measuring meaningful objective goals and very specific ways to obtain those goals. And I think that's the key point here, is meaningful. Having some kind of objective that's meaningful to them. To just say, I'm going to be sober for a day, well, yes, that's meaningful. We need to pull in those short-term positive consequences. What happens when you're sober for a day? You're more clear-headed in thinking. You may be able to go around family, and giving those individuals additional treatment plan options. Next slide, please. The fourth step in the community reinforcement approach is talking about behavioral skills training. And this is utilizing instruction and role play with feedback to teach. Again, I know that we're talking about individuals who may be in a clinic, they may be in an ER. You may not have a lot of time with them, but I really truly believe that there's snippets from each one of these steps that as providers, as practitioners, clinicians, that we can all take little snippets out, and we have the time to really just take that few seconds to say, okay, let's talk about how your communication skills are either when you're sober or, when you're using. Do you notice a difference in your communication skills? I can emphatically tell you that I know when my adult son is using substances truly by the way that he communicates with me. We go from a normal communication method to, a lot of street lingo and a lot of street language. And I really see like a really hyperactive, hyped up, fast speech. And so really getting them to identify, have you noticed a difference in your communication skills? Definitely, have you noticed a difference in your problem solving skills from when you're sober versus, when you may be using substances? And really helping them identify being more assertive to high-risk situations that may trigger them to want to ingest substances, and really helping them establish boundaries with other people. This has been huge in the relationship that I have with my adult son, is giving him this space and allowing him to say what things trigger him in my household to want to use substances, and holding space for that and not getting offended by that, or not discounting what he's telling me, because his perception may be it's tense. There's a lot of activity, there's a lot of commotion. I don't like when you say A, B, and C. it's very triggering to me. And then allowing me to own that and say, how can I change that with you? And then telling him, well, these are my triggers as well. And really coming up with a drink/drug refusal training. Okay, so if you're triggered, what do we need to do to change that so you're not wanting to seek substances? Next slide. The other thing that's really important in the community reinforcement approach and the CRAFT model is really talking about job skills training. And again, I understand, you in your current roles may not have time to deal with this. This may not be on your radar. But it is important to talk about it in the CRAFT model, is really offering resources and partnerships with local organizations on helping these individuals to obtain and keep a valued job. And I think that that's really important, that we discuss a valued job. Understanding, I think people sometimes are like, well, you could do this, or you could do this, or you could do this. But really needing to understand what holds value to the individuals, what do they deem a valued job, and how can we offer those organizations or resources or partnerships. Job skills training is really where peer recovery coaches come into. And the ER specifically, a lot of ERs typically will utilize peer recovery coaches, especially when they have individuals coming in with overdose or substance use disorder as a diagnosis. They'll call in a peer recovery coach. That's that individual who has walked in those shoes, has themselves utilized substances, have been able to maintain sobriety, and then are doing something that they feel helps not only their own sobriety and recovery, but they feel valued, that they're giving back to that community that they were once a part of. I have a little hesitation on the peer recovery coaches, and only because I understand both sides of the coin. Most often, any type of peer recovery platform will say that the individual has to have at least 12 months of sobriety underneath their belt before they will utilize them as a peer recovery coach. I understand that, but I also understand that maybe we need to look at that model. And again, this is just coming from both personal and professional experiences to really question that model. I understand why you want somebody having the 12 months sobriety underneath their belt, but 12 months is a long time in this particular arena when you're dealing with individuals with substance use disorder. I know oftentimes my son can get a really good 3-4 months under his belt of sobriety. But in that 3 to 4 months time, when he's looking for opportunities and options and has even looked at being a peer recovery coach, he's been turned down because he doesn't have enough days behind him being sober. And I typically often will see that relapse over and over and over in individuals, not only my own son, but other individuals, that they hit that 3 to 4 month mark. And so I really think it's something that we should sit down and kind of discuss that peer recovery. What can we do in the interim, and that when they hit that 3 to 4 months, to really get them to work towards being a peer recovery coach? Are there classes? Are there things? Can they begin shadowing another peer recovery coach until they can branch out on their own? And then part of job skills training is also finding additional avenues for employment resources. Most of these individuals who are dealing with substance use disorder are also dealing with criminal histories. Oftentimes it's theft, because that's what they have to do to obtain their substances. And so that's making it extremely difficult for individuals out here who truly want to make a change, who truly want to start living a sober lifestyle, that they're not able to obtain employment or valued employment because of that criminal history. Again, it's just another thought. It's another, let's open this up for discussion. Let's figure out, is there ways that we can support and, you know, look outside of ourselves to even engage individuals in both the criminal justice arena, you know, from an ER perspective, and employers. Would you be willing to take a chance? What do you need to take that chance on this individual? And really, I think just bringing the community together as a whole to ask the tough questions. Are we doing it right? I get that we've always done it this way, but maybe we need to question the status quo. And that brings in that considering the redesign of steps that are needed to obtain valuable employment. Next slide, please. Then we talk about, in the CRAFT model and the community of reinforcement approach, is a social and recreational counseling. Again, I understand you're not going to probably have to deal with this in the ER. You may not even be dealing with this in an outpatient setting. But these individuals who are utilizing substances and are dealing with substance use disorder are also dealing with several other comorbidities, whether it's physical or mental. And you're going to see these people over and over and over, both in your clinics. You're going to see them in the ER. And you're going to get to know them because they are showing up so much. Not always, but most of the time, that's typically what we're seeing, is those repeat individuals. They're coming in for repetitive appointments, repetitive, you know, emergencies. And so I think there is an opportunity here to really build a little bit of a social and recreational counseling, especially if you're always working and you happen to see this individual and it's the 6th time you've seen them that month. You've established a rapport with them, and trying to find alternative outlets for them to deal with daily positive and negative events. I think what's important here in this slide is, and I learned this again through the CRAFT training, as well as in my personal experience, we think of triggers, and going back to the communication skills and what are triggers, and there's positive triggers and there's negative triggers, but never really understanding the positive trigger. We really focus on negative triggers. And if we can also understand that positive things and positive events are also very triggering for an individual as well. They're in this mindset of survival. They're in constant survival mode, and they don't often believe in positive events, that they're always waiting for the shoe to drop. Something as simple as, I was sober today, I filled out 20 job applications and I got 5 phone calls for interviews. And while we will look at that and say, that's positive, that's great, the individual is holding on to this piece of, when is the shoe going to drop? Yes, this is good, but I'm not used to having positive things happen for me. And so they're kind of sitting there with bated breath, waiting for the other shoe to drop. And those can be triggering emotional responses as well. And that can lead to use, almost like a self-sabotage and a self-destruct. It can include environmental changes, social group changes, as they're moving away from the group that are using substances, and they're surrounding themselves with other social groups who are not using, who may be in their own recovery and sobriety journey. Those things are going to elicit an emotional response for individuals as well, and really giving them good foundational skills, communication skills, behavioral type skills to be able to navigate that positive change just as they would navigate a negative change. And then really trying to understand the time frame changes, looking for when does this individual typically use? Is it a certain day, a certain time, or a certain situation? I know often like late afternoon, early evening is when I've always been on heightened alert for my own son and his use. And it wasn't until I obtained the certification in craft and really understood craft that I even knew that there was a pattern, and that I even knew to look for a pattern. Was it a day of the week? You know, I think most people think that, you know, we're looking at weekend. There's a lot of alcohol use, maybe more illicit drug use during the weekend. But individuals who are really dealing with substance use disorder, it's not that where you're seeing it just on the weekends, that they're out with a group of friends. You're seeing that use when they're alone and by themselves, and when they're triggered more with their own thoughts, which typically tends to be later afternoon, early evening, middle of the night, when those negative emotions and negative thoughts are, the day is starting to wind down. The evening is coming, and it's kind of just traditionally more of a slower pace in the evening versus the day. So I didn't even know that there was a pattern to my own son's use until I actually sat and looked at it and was able to come up with different alternatives for him during those time frames. Next slide, please. And then part of craft and part of the community reinforcement approach is really that final step in talking about relapse prevention, understanding and identifying high-risk situations, high-risk times, high-risk individuals, and anticipating how to react, respond, and cope with a lack of judgment. Offering different ways to individuals to identify a relapse situation, utilizing some of the forms and the tools that are provided for you in the reference section in the early warning monitoring system, and understanding that CRA functional analysis of relapse. The CRA functional analysis of relapse, though, is really to be utilized for a recent relapse within 1 to 2 weeks. So that's that individual who may only have 1 to 2 weeks of sobriety under their belt, and you see them again in the ER or your clinic because they've relapsed, they're using again, it's only been 1 to 2 weeks. And so I just want you to understand and know kind of what that functional analysis is really meant more for that recent relapse, not that individual who has that 3 to 4 months, maybe even 6 months or longer under their belt of sobriety, and then they've relapsed after that. Next slide. And then talking about relationship counseling. This is really focusing on improving interactions between patient and client and their immediate support system. That's the partners, the family, or positive friend circles. It's requesting them to have minor changes to achieve obtainable goals. One of the ways that you can look at this and utilize this both in the acute care setting and in an outpatient clinic setting is greeting one another within the first 5 minutes with a simple pleasantry. Don't overlook someone. Look them in the eye, greet them, smile at them, letting them know that as a human being and an individual, they matter. Then really talking about completing a chore by a certain time, at least once a week. This is more for that individual and their family, where the individual may be living with the family member, or even in a group home, sober living home setting, is giving them very clear, defined, obtainable goals. Practicing de-escalation techniques together and discussing what behaviors cause stress and triggers for each other and how to address those triggers when faced with them. Kind of going back to my own story with my son, in that really giving him the space to come to me and say, your words are triggering me, your posture is triggering me, or your eye rolling is triggering me, and allowing him to be able to say that to me and being able to stop in that moment, as well as me being able to say, these things trigger me: your fast speech, your chaotic, controlled, unorganized behavior. And I think that there's ways that we can take these, even though this is meant for more of a long-term counseling type of a situation, there's little snippets in all of these that we can take and utilize in the immediate acute care outpatient ER setting to make really positive impacts with our patients and with these individuals. And then clearly identifying boundaries around unsafe practices, communication, or situations, and having a plan of removing yourself immediately to safety should any of these things escalate. We teach de-escalation in the emergency room setting all of the time. Again, utilizing de-escalation with substance use disorder individuals is crucial. When their behavior is being manipulative, or their speech is being manipulative, or it's being even aggressive, that having that ability to stand up and say, I understand your frustration. I am happy to work through that with you. However, I am demanding that this is my boundary, that I need cooperative speech and cooperative communication back. And then understanding if it's escalating to immediately remove yourself to get to safety. Next slide. So this is my made up word for you today. It's my word of the day. As I've listened to podcasts and different things like that, and really talking about different communication techniques and methods, and how do we communicate with individuals. And I really take these lessons to heart. I look for ways every single day to improve my own communication to every single person that I come across, to present myself in a more empathetic and compassionate way, and to really make people feel as though that they are seen and heard. And so in listening to a podcast, they were talking about grace and compassion. And I kind of smashed the word together, and I was like, that's it. That's what I'm trying to relay to you today. Gration, the intersection between grace and compassion. It's meeting each individual at certain points in their life and realizing that you cannot force change, but you can provide grace and compassion to light a path for change and plant a seed for change. It's done by the language we use, stopping and acknowledging the present moment with direct eye contact, seeing over and past mistakes and poor choices, and compassionately seeing individuals as human spirits capable of more than their present situation, and believing that they have value to give. Next slide. So, as we're wrapping up this particular session and talking about craft and community reinforcement approach, this is a list for you of providers and trainers. As you can see, there really aren't any in Indiana. There are very few. And the two providers that we did have in Indiana, when I reached out to them, they are no longer practicing. And so these individuals, Robert J. Meyers and Jane Ellen Smith, number one, they are actually available by phone. I've spoken to them personally. They are the founders of this craft model. And they are more than willing and more than happy to provide training, to sit and discuss their model with individuals, and to help hook you up with people that you could actually obtain training through. Allies in Recovery is one of the substance use disorder platforms that I utilize to obtain my craft training. And I don't know if you remember last year when we had Dominic Simone Levine as part of our presentation on substance use disorder. Maybe some of you weren't logged on last year, but she's the founder of Allies in Recovery. And this is a lot of the information that I get comes from this website. It comes from this particular organization. They're phenomenal about supporting clinicians, practitioners, and providers and dealing with individuals in substance use disorder, as well as phenomenal in providing the craft training, which was a 2-day training, all-day training that I took and that I went through. Because I'm not an LSW, I can share the information. I can say, here's how to obtain your certificate that you're trained in craft. I can utilize it in my own personal practice, but it's tweaked a little bit for LSWs, MSWs, licensed psychologists, and psychiatrists, individuals in a different manner. The Center for Motivation and Change, again, is another great resource. They have so much information on changing our language, changing stigma, really bringing people together to effectively have different behavioral modification therapies. And how do we do this in the short time that we see these individuals, either in an emergent setting or in an outpatient clinic setting? Next slide, please. These are the references. Each one of these hyperlinks will take you, especially the top one, the Robert J. Meyers, Ph.D., is all of the forms that are utilized in craft. When we were talking about the functional analysis form, you can find all of the downloadable forms there at the references. And I'm going to share my video here real quick. It's good to see you guys all on video. I know some of you guys hopped on after we started the presentation, and I apologize. I think there were 2 different links, and there was some confusion about that. It was recorded, so you're more than happy or more than welcome to utilize the recording and go back to be able to take this forward, train people and individuals in your own organization. I really wanted to just make a key point note here. And part of the reason that I do this is for a personal reason, and I've talked about that extensively throughout several of these presentations. In June, my son relapsed again, and he was in a horrific car accident. He was in ICU. We were prepared to lose him. Long story short, he really did a number on himself. He had multiple internal injuries. And what I wanted to share with you, though, was not so much that, is when he was recovering and I had the opportunity to step back and be the mom and not be the nurse, and really observe the nurses who interacted with him. There was a very distinct line drawn between individuals who were either burnt out in their own work or didn't have the tools that we're kind of providing here today to talk to individuals who are dealing with substance use disorder, who are in acute addiction. And I saw the response that my son gave to individuals who were dismissive, were not giving grace, were not giving compassion, and really were just looking at him as that language, you know, just another addict. Versus the two nurses who were at his bedside and made sure that they made eye contact with him, made sure that his pain was important to them and that they weren't going to discount his pain because he was in active addiction, but really took the time and the opportunity to speak in a compassionate manner, giving him grace, seeing through and seeing past the fact that he was an individual who had a mother who loved him very much and loves him very much, and really sat and talked to him. And there's one nurse in particular who stuck out, who had a child that she lost to an overdose. And her taking the time to really sit and talk to my son and just say, this is me on the flip side, having to deal with not having my son here, and providing him opportunities and resources and making sure that the peer recovery team was contacted, and really just saw him as an individual and didn't preach to him, but said, you know, your behavior and what you're doing is really hurting your family and it hurts me. And her being, you know, a stranger to him, but bringing in that compassionate, vulnerable point and key piece. I saw a change in my son really for the first time, in that there were tears. There was, I need your help, Mom. I can't do this. I don't want you to be like that nurse, and having to bury me and carry that pain and trauma. And I'm just so thankful and grateful to her that without having gone through any of this training, without having really been given any formal training in communication or behavioral modification therapy, she figured it out and she did it, and she truly made a difference to me, and she made a difference to my son. So I just want to leave you with that last piece, is to really, you just don't understand and you just don't know by just looking at individuals and humanizing them, changing your language and giving them a little bit of gration, what an effect that has, not only to the individual, but has long-reaching effects to family members, myself included. That is it for my presentation today. Are there any questions for me?
Just to let you all know, you can use the chat function to submit your questions. If you would rather ask your question verbally, you can use the raise hand function and we can unmute your line. You find those by hovering your mouse either at the top or the bottom of the screen, depending on which view mode you're in. And the raise hand function is under reactions, I believe.
All I can do is really encourage you to look at this craft model. Feel free to reach out to Dr. Meyers. He is more than willing to answer the phone and take calls and emails. I know he's a lot, he's super busy, but he is easier to reach via email. He will return your email to obtain more information on that. These are just some of the steps that are used in craft. These are some of the things that you can look at to maybe begin having conversations in your own organization to see if this is a fit for you. you know, there's so many different models and behavioral modifications and different things like that. This is just another piece to the puzzle to say, can we start having questions? Do we need to look at how we're approaching individuals? And is this going to be helpful or beneficial to us?
I'm still not seeing any questions come in. Okay.
Perfect. Well, it has been a pleasure. Please feel free to reach out to me too as well. My contact information is in the slides, my phone number and my email. I am more than happy to help with anything that you may need. And thank you so much for giving me your time and listening and letting me share a little bit with you.